es evidente que realmente es un gran apoyo tener un grupo conformado de especialistas que puedan tomar una decisión oportuna para salvar una vida, sobre todo en aquellos pacientes con riesgo intermedio alto, que por ahí siempre viene la discusión de cuál es el paso a seguir. Viendo el éxito en otras patologías como el código stroke o infarto, seguramente la instalación de equipos PERT es muy importante y va a disminuir la mortalidad en todo el mundo. El doctor Sameh nos va a comentar un poco de cómo él dirige su equipo en Estados Unidos.
By raising hand, who does TAVI here? TAVI? Okay. So you guys have a team, right? You have a cardiothoracic surgeon, you have a cardiologist, you have an echo doctor, and the reason TAVI become almost mandatory to have a team, because we know there are better outcome with program like a TAVI program than just someone just does TAVI. Same thing for if you do a TVAR in a thoracic aortic therapy, you need a team. So we've heard over and over and over how team is important, because one opinion is not as good as 10. Of course, too many opinions can be a problem too. From our experience, what you mentioned is absolutely accurate. I think having different multidisciplinary means multi-specialty team is very important, because each has their own input. For example, the case you presented, someone would have told you, why not just give an IV TPA, TNK, and this patient was cardiac arrest, so maybe the patient had a reason not to. But even having a pharmacist, a pharmacologist, to be part of the team to tell you what the doses is that you need to use. So I think it's extremely important. We started with this phone call, Zoom call on all the patients, and we stopped doing it because we didn't have enough people that had interest outside the operators. So what we changed it, and our operators has had a lot of experience over the last 10 years. So we make the phone call on a case-to-case basis. So Mass General has that unique protocol because they're a very academic program, and that's easier for them. For us, is a little bit different. But if I have someone with a clot in transit, we make phone calls to figure out if we can do it via catheter or should we do surgery. Any patient that we think will require a mechanical support, an ECMO, we'll have that phone call. I think when you start, it's important to have everybody involved because you give them an ownership of the program. And the last thing I would say that you may or may not mention in the talk, if you are building a PERT program, don't forget to collect your data from day one. Similar to what you have in TAVI, you collect the data. So after your first 100 cases or 200 cases, you say, I have a mortality of 1%. I have patients who leave the hospital in 24 hours or 48 hours of this percentage. That's where you can present your administrations and present your society and community and show the importance of what you do. If you don't start from the beginning of having data collected, it's very hard to do it at the back end. Yeah, I mean, that's what I have. And you covered very beautifully. I mean, there's some guidelines. We have our own algorithm. It's a little bit different. But Mass General has a nice one. MD Anderson has a nice one. Cleveland has another one. But you can make your own that adapt to your team. I don't have anything else to say. I think you covered very nicely. I'm open for question or if anybody has a comment.
Si hay alguna pregunta del público, la pueden hacer.
Buenos días, doctor Giraldo. Con respecto a la experiencia de ustedes, número de pacientes de pronto que tengan en el grupo de trabajo, resultados y seguimiento de pronto a 6 meses, a 1 año, ¿qué datos tienen? ¿Cómo los están siguiendo? ¿Caminata de 6 minutos? ¿Cateterismo derecho control? ¿Qué le hacen a esos pacientes? ¿O angio de control? ¿O cómo lo manejan desde la experiencia de ustedes?
Gracias por la pregunta. Desde hace un poco menos de 2 años estamos desarrollando la clínica de TEP y esta clínica incluye los pacientes de TEP agudo y los pacientes de TEP crónico. O sea, incluimos ahí no solo los pacientes que hacemos trombectomías, sino también los pacientes que llegan para angioplastias pulmonares con balón y todo lo estamos centralizando en una misma clínica de TEP. Todos esos pacientes tienen seguimiento por consulta al mes, a los 3 meses, a 6 meses, al año, y a todos se les realiza biomarcadores, básicamente troponina, BNP, se le realiza ecocardiograma también seriado, varía pues según el paciente y demás, pero a todos se les hace eco. Y a los 6 meses todos los pacientes, principalmente, o sea, mandatorio en crónico, todos tienen cateterismo cardíaco derecho y según el caso, cateterismo cardíaco derecho también para los de agudo, que tuvieron, sobre todo los de TEP masivo, les pedimos cateterismo cardíaco derecho para ver, para ver pues resultados sostenibles hemodinámicos en el largo plazo, y 2, para tener información, data, para poder hacer publicaciones y poder tener más consistentemente la información. Bueno, no tengo ahorita el número exacto, de hecho eso ya lo estamos sumando para poderlo publicar, pero está en proceso de publicación, pero no sé, debe ser algo como unos 20 o 30 intervenciones agudas en ese tiempo y más o menos unas 70 crónicas, más o menos. Entonces, la idea es, como bien lo mencionó el doctor, tener los datos desde el principio y tener todas las bases de datos desde el principio y luego no sufrir buscando retrospectivamente qué fue lo que le pasó a los pacientes.
So for us, we're lucky to have a pulmonary hypertension clinic in our hospital. It's run by a cardiologist. Our protocol is if the patient get an intervention by ecosonic therapy or any thrombectomy device or surgical, they follow up with the operator who did the procedure within 4 weeks, 1 month. And that's because we assume that they can afford their blood thinners. And you'd be surprised how many they cannot afford Xarelto or Apixaban or something like that, and you have to switch to Coumadin. That's number one. Every patient followed in 3 months with the pulmonary hypertension clinic with an echo, 6 minutes walk, venous mapping, and I'll comment about why, and a VQ scan. We used to do CT scan, and now we do VQ scan because it's more accurate for CTEP. The reason for the venous mapping is the clot has to come from somewhere, and the most common place is the legs. There was a trial that showed 23% of patient with PE/DVT has May-Thurner syndrome or central vein compression syndrome. And you'll be surprised how many of those patients come back with another clot a year later, and because they were never been tested or treated for a central vein compression syndrome. So that's why we do venous mapping. It's an easy way to confirm the clot is gone, and if there's a deep reflux, we go back in and do a venogram and stent if needed. In Dallas, there is 25 hospitals, different hospitals. They belong to 4 different healthcare systems, and we were the first hospital to do PE therapy in the South area for the last 10 years. Now, out of the 24, 15 of them do PE therapy, 20 they do DVT therapy, and only us and another hospital has a program where you follow up on those patients. So we see a lot of this patient in our clinic that were done somewhere else because they've never had a follow-up, they never had echoes, they don't know how long they need to be on blood thinner. And the last thing, we do not consult hematology as inpatient, but 100% of the patients see a hematologist, a blood disease doctor, as an outpatient to make sure why this patient had a blood clot. You need to have the answer. The question is how to treat it. We showed echoes, great. Thrombectomy is great. Depends on the patient, of course, which one you want to choose. But the question is why they had it in the first place. And if you don't have that answer, this patient will come back with another blood clot.
In your experience, what do you think about the size of the device? Is important the size of the device, or is most important the power of operation of the device?
Yeah, I think that's a great question.
What do you prefer, the big size device or this device with a continuous operation?
Great question. We have both. We have all the devices we needed. So we pick and choose, depends on the patient. So your question is, does the device size matter in terms of treating the clot? And by that, 24 versus 16, because those are the only two. Number one, the size of the sheet, to begin with, it doesn't matter at all. So a lot of operators don't do a thrombectomy because they're not comfortable putting a 16 or 24 sheet in the vein or going through the heart, which for people who does TAVI and EVAR and TVAR, that's just a joke. We do it in the artery. The vein is much forgiving. So from that perspective, I think it's pretty safe. It has shown to be safe. It's shown to be safe to put a 16 or 24 through the heart to the lung if you are using the right tool, which is a stiff wire. You never push your catheter through a glide advantage or a glide wire or soft catheter, soft wire. Always have to have an amplat, super stiff, or a supracore. 16 versus 24, in our algorithm depends on the lesion location and size. If I have a saddle, very large, very proximal clot, I prefer the 24. It's just because if you try to do the 16, what's going to end up happening, two things. One, we always look at all these films as 2D image, but it's in reality that artery is a 3D. So you may be just rotating around and not even close to the clot. But with a double curve, that's a solution to it. And I'm using a 16 versus, I would say I would not use an 8 and 12 anymore when you have the 16, because we used it for a long time. That's the only option we had. And there's a lot of blood loss. 16 has less blood loss. So if I have a really big clot in the saddle proximal part, I would like the 24. It just have better grab on the clot and you take it as one piece. But if I have anything that is in the mid or segmental, like what the cases I showed you, those cases are much better to be taken by the 16 because it's much easier to curve, much easier to direct, and you're able to have and you will be able to tell right away if you're in a clot or not. Where in the 24, you take the suction, you pull out. If you've done it before, you pull the negative, you pull, and you may have to pull all the way to the IVC before you have that, we call the whoosh sound or the. So you don't want to do that with the 16. Your 16 can be there, you suction, you stop, take a picture, you go back. So the algorithm for us is large, very large. I will do a 24. Segmenta, I like the 16. But really, I think what I also recommend, if you're going to build a program, is try to treat the first 10 or 15 patients to be a little bit of a more stable patient. I think the patient you presented, a very sick patient for someone, you've done it before, so you had that experience. But if you're doing it for the first time, this is a really sick patient. If a PA pressure of 100, that's the other point I want to make. That's something you may or may not ask, but eventually when you start practicing, they're going to become up, is anesthesia for those cases. So our team is divided. 6 operators are interventional cardiologists, 4 operators are vascular surgeon. We alternate call. And initially we had our experience where our colleague in the vascular surgery, they do it on OR, so every patient got intubated. We had 3 ECMO after the extubation because the patient just crashed. And we decided, and that's during the ECOS time, not thrombectomy devices, during the ECOS era. So we recommended that no patient get intubated, period. No patient get anything more than a fentanyl and Versed, period. And if the patient is sick, no sedation at all, just local anesthesia, local, lidocaine. And we have not had any of those happening again. So anesthesia, in this case, if the patient is crashing, or we had a case a couple of weeks ago, the patient could have been moved without intubation. We intubated the patient in the ER. But if you're electively intubating the patient, you will lose all the patient on drive, and this patient can spiral. So that's just something to, just a thought about anesthesia.
Damos por finalizada la mesa de tromboaspiración y tromboembolismo pulmonar, así que muchas gracias a todos ustedes por su aporte, su presencia.